Okay, good morning, good afternoon, good evening po sa lahat. Saan man po kayong panig ng mundo naroon. Welcome to our 171st episode of Stop COVID Deaths webinar series brought to you by the University of the Philippines. Thank you for being part of our credible online community. At sana po marami po kayong matutunan sa araw na ito. Pagpaumanin niyo po, nagkaroon po tayo ng technical difficulties kanina lang po, and hopefully smooth sailing na po ang pag-login at panonood po natin dito sa ating webinar for today. For today, we'll be discussing vascular care in the Philippines, which has come a long way from rudimentary beginnings to state-of-the-art practices. Sa Pilipinas po, and specifically for today, we'll be looking at from the lens ng Philippine General Hospital. Early vascular care, limitado po sa scope with few specialized interventions available. Over time, as healthcare infrastructure has improved and medical knowledge expanded, vascular care began to evolve. And one of the defining features of its evolution is the integration ng cutting-edge technology. So mayroon na pong state-of-the-art equipment and innovative procedures which have become more accessible, allowing for earlier and more precise diagnosis and treatment, and the use of advanced imaging techniques, minimally invasive procedures, and endovascular interventions. These have revolutionized the field, enabling healthcare workers to provide a better care to their patients, and this advances not only enhance patient outcomes but also improve the overall landscape sa ating healthcare sector. I'm Dr. Raymond Francis Sarmiento, Director of the National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. Always a pleasure to be with all of you during our regular Friday, and always looking forward. It's my pleasure and honor po to co-host this program together with our adjunct research faculty at the National Telehealth Center, also internationally renowned public health communications expert, Dr. Susie Pineda Mercado. Dr. Susie? Yeah, you're on mute, ma'am. There we go.
Hi everyone, good afternoon Raymond. Good afternoon po sa lahat ng mga kasama natin sa Zoom. It's great to be here and have another session of Stop COVID Deaths. We are really very fortunate to have this opportunity to reach out to a lot of people, not just in the Philippines, but around the world. And I'd like to greet all of you who are with us on the Zoom webinar. And of course, those who are watching via live stream of TVUP YouTube channel, as well as the UP System Facebook page, TVUP Facebook page, Stop COVID Deaths Facebook page, and of course, all of you who are watching from TVUP Signal TV Channel 101. And we all have access to the playback. One of my favorite things to do is to watch the lectures again. So I encourage you to go back to the lectures. This one is going to be really a very good presentation. So we strive to bring you the best doctors and experts. Our main presenters are Dr. Leoncio L. Cao Jr. or June Cao, who is a practicing vascular and endovascular surgeon from the Department of Surgery of the UP Philippine General Hospital, and Dr. Aldous S. Cabasa, who is a practicing thoracic and cardiovascular surgeon from the Division of Thoracic and Cardiovascular Surgery in the Department of Surgery of the UP PGH. Finally, synthesis and closing remarks will be delivered by Dr. Stella Jose, who is the head of the Office of Expanded Education and Training at the UP PGH and is our foremost coordinator for our speakers. So we are going to have a lot of interesting discussions. Raymond, 171, ang dami na, no? It's
That's true.
I know. And anyway, but before we go to that, as you know, we started talking about COVID, but we have expanded our discussions to include all kinds of updates in clinical management and in public health. And I know all of you are waiting for the latest news on health and medicine. And it's for this reason that we bring you the news update.
Okay, for our very first news update for today, pag-uusapan po natin, parang may tinatawag po kasing coin bank program. And this has been helpful po in eliminating neonatal deaths in the town in Abra. The municipality po ng Peña Rubia in Abra province. Ito pong coin bank program na ito, it encourages those who are pregnant to save money for emergencies, and has been a major factor in the town's zero neonatal death rate since 2000. 2012. So meron pong nag-deliver po na pasyente, delivered her third child in August 2016, and in a phone interview with the Philippine News Agency, that she only added 3,000 pesos to her savings to cover the 8,000 hospital bill, and they were able to save 5,000. Very, very handy because she underwent cesarean section in a hospital in Bangged in Abra Province. Very grateful. Ang tawag po nila sa proyektong ito, Banco de Nueve project, being implemented by the Rural Health Unit in the municipality of Peñarubia in Abra Province with the help of village health workers monitoring their savings po. Very, very important. They, sabi po ng kanilang RHU doctor, I believe, Municipal Health Officer po, Dr. Elsa Dangani Gonzalez, when they started the project in 2016 to help pregnant women and their families. They don't charge, and then for the laboratory, the LGU subsidizes the services, which are 100% free to the pregnant women and 50% for other clients po. How about you, Dr. Susie?
Okay, so responding to rapidly changing climate, the World Health Organization has unveiled a new operational framework for building climate resilient and low carbon health systems. Released in the lead up to the upcoming United Nations Framework Convention on Climate, or the COP28, this comprehensive framework is designed to enhance the resilience of health systems while simultaneously reducing greenhouse gas emissions to help safeguard the health of communities worldwide. According to Dr. Tedros, the Director General of WHO, around the world, healthcare systems are vulnerable to the impacts of climate change, but they also contribute to it. So this is a way of reducing the footprint of our health facilities and helping countries develop a roadmap for doing just that. So that's our news for today. We'll be back next week with more news for you on the News Update. Okay, and we're back, Raymond. So, very interesting topic, back in the day, siguro yung iba makarelate sa akin. If you have varicose veins or, some kind of vascular problems that are kind of like, the problem is aesthetic, ay magsastockings ka na lang, tsaka magpapantalon ka na lang, tsaka sin mo na lang. Kasi there was no way, or it's too expensive to operate on it. No. On the other hand, there are other kinds of vascular problems that require very, complicated surgery and really beyond the reach of ordinary people who have issues with their blood vessels. Kasi alam nyo, we were talking about what's the word we're going to use, diba? Kasi yung ugat, usually it means nerve. Pero in this context, we are talking about your blood vessels and how the Philippine General Hospital has developed really some innovations in surgery for blood vessels that are not very, well, they're a little bit invasive, but not as invasive as before. And they have faster recovery time. They're definitely cheaper. There's definitely less pain. So I'm very excited to hear about this. And again, we bring you the best speakers for today from the Philippine General Hospital. Okay, Raymond, but before we do that, we're gonna hear from the person on the street, no? Parang meron tayong mga na-interview. TVUP, I think, reached out to some people to kind of get some of their thoughts on vascular surgery. And you're gonna introduce that, Raymond?
Yes, thank you so much, Dr. Susie. So, to set our discussion into context, we always put up this very, very short video po called Person on the Street video. So dito po, the questions that we ask to our interviewees are as follows. Ano po ang alam ninyong mga sakit sa daluyan ng dugo? May kakilala ba kayong may mga ganitong sakit o sintomas na kagaya ng hindi humihilom na sugat, sumasakit ang binti kapag naglalakad, yung mga ganun po. May kakilala ba kayong naoperahan ang varicose veins or merong aneurysm? Ano ang mga gamutang naranasan nila? Please watch this.
Wala po ako masyadong alam when it comes to mga sakit sa ugat.
Oh yeah, hypertension. We have some family members with varicose, and also aneurysm actually.
So wala akong masyadong alam sa ibang sakit sa daluyan ng dugo. Pero most commonly yung naririnig ko is yung mga aneurysm, varicose veins, gano'n.
Counted ba ang pre-hypertensive? Yeah, yun, I'm aware of that. And actually, yeah, that's it, hypertension.
Ang alam ko lang po at yung familiar ako is yung kapag nag-block yung veins sa heart, tapos nagkakaroon ng sakit sa puso, ganyan.
One side of my family is diabetic, so one symptom kasi of that is our wounds that don't heal easily. And then I know one of my parents, my dad also has varicose.
I know someone na recently na inatake siya ng cerebral aneurysm, kasi hindi niya like it was very sudden kasi like nakaramdam lang siya ng headache, ganyan. Tapos sobrang severe na, tapos hanggang sa nahirapan na siya magsalita, tapos wala siya kita, ganyan. Hanggang sa namatay siya, ganyan siya.
Actually, alam ko yung dad ko is hypertensive. And ako, when I was in high school, I was pre-hypertensive. So, yeah. Operation, no. Pero I know yung mom ko may varicose veins, yeah.
Nakilala ko na may chronic venous disease. Ang symptoms nun, nagkakaroon siya ng lumalabas yung ugat niya, nakikita, nagiging visible. Like, spider veins, like that. And nagiging varicose veins, then nag-swell, leg swelling, and then nagbabago din yung kulay ng vein, yung leg niya na yun.
To prevent hypertension, I know they take some maintenance meds. I don't know what specifically though. As for like my parents' varicose, they're not taking any meds, but the doctor told them to try to get the blood flowing. So get their leg raised every now and then, that kind of stuff. Yeah.
From what I know, I think very mahirap kasi makatch yung aneurysm unless it's like it's ongoing na. Parang there's a 50-50 chance na survivability mo kapag nagkaroon ka ng rupture na cerebral aneurysm. Right.
So far, yun pa lang yung nakwento sa akin. Pero yung surgery is wala pa akong kilala na nakapag-undergo ng surgery sa ugat.
Okay, thank you so much, TVUP. So something very, very interesting po, no? There are concepts po that are familiar with the common folks on the street, but I think there's a need to be more, let's say, more detailed in the explanations. Ano pa po yung mga kailangan na malaman ng ating mga attendees, especially for those who will be attending this webinar. So we are very, very lucky that we have the top experts po on vascular care to be talking about this topic. And we're hoping na yung pong ating na-interview dun po sa person on the street video, sila rin po ay magpapakita dito po at manonood ng ating webinar for today. For those who are asking, little bit of housekeeping lang po. Certificates of attendance will be given to those who have watched at least 50% of the webinar duration. We have already sent out certificates of attendance for webinars 1 to 170. So if you feel you should have received a certificate but did not, please email us at stopcovid@up.edu.ph. We also encourage you to join po itong pong ating mga groups for you to be able to be more updated po with regards to any announcements. Meron po kasi mga nag-direct message po sa atin na nahirapan daw po sila mag-log in, but I think upon further inspection pa, it's more of having access to the correct link na pagre-registeran po nila. For our webinar,
Raymond,
yes, po.
I also got the same message,
Mm-hmm.
parang hirapang pumasok. Pero
Yes.
parang okay na ngayon.
Mm.
Yeah, anyway, for those who are coming in late, I'm just chiming in, no? You can always watch the playback. And tawagin yung ibang mga kasama nyo dyan, magaling yung speaker natin sa totoo lang.
That's true. That's true.
So Go ahead, Raymond.
Yes, thank you, Dr. Susie. For webinar today, we'll follow our standard panel discussion format, and after our speakers are presented, which will be followed by a Q&A session. But before we proceed to our webinar proper, we have a cute, very, very short intro video for our fun quiz segment for today.
Hello? Hello? Hello?
Kumusta na kayo lahat?
Hi, I'm Doc Susie, the mini Doc Susie.
And I'm Doc Radar, the mini Doc Raymond. Are you ready to have fun? Simply open your browser to www.slido.com and enter your code to participate. We will discuss your answers during the panel discussion later on in the program.
We will have it flashing on your screen in a bit, and we look forward to your answers. Masaya at madali lang ito. Join na!
Okay, thank you so much, TVUP. Can we have on the screen? There we go. Pati po sa Slido po sana, can we have them on the screen? Okay, for those who are joining us outside of the Zoom, Facebook, YouTube, or sa ating Signal TV Channel 101, you'll still be able to participate in our fun quiz by opening up your browsers, typing in sa address bar slido.com, and when you are prompted, you enter the code 6510096. That's 6510096 for you to be able to participate in our fun quiz. We have 2 questions for today, and the questions are as follows. Question number 1. Which parts of the body can aneurysms occur? Letter A, is it brain? Letter B, chest. Letter C, abdomen. Letter D, legs. Or E, all of the above. I'd like to take this opportunity to greet those who are joining us from Bataan, from General Santos City, maraming salamat po. From Cavite, from Deca Homes, Loma de Gato in Marilao, Bulacan, from UP Diliman, the University of Rizal System Health Services Unit din po. Those joining us from Bulacan Medical Center Department of Pathology, Laboratory Medicine, and Molecular Diagnostic, as well as those from the University of Northern Philippines in Vigan City in Ilocos Sur, Department of Education Regional Office 5 in Legazpi City, Department of Health in Tacloban City and Leyte, Valladolid District Hospital in Valladolid, Negros Occidental, Tanho Medical Clinic in Plaridel, Misamis Occidental, and the Socsargen General Hospital in Surala, South Cotabato. For question number 2 reads, ano po ang benepisyo? What are the benefits of endovascular surgery? Is it A, smaller incision, B, konti po ang blood loss, C, shorter hospital stay, D, faster recovery, or E, all of the above? So we, as you know, we are also being viewed internationally po. So we'd like to take this opportunity to greet our mga suke, o mga masugid na taga-subaybay, all the way from Los Angeles in California, United States, Manteca, California, also in the United States, Chonin Hospital in Taipei City in Taiwan, Luigi Ali University of Blida 2 in Blida, Algeria, the Canadian Medical Center in Dammam, Saudi Arabia, University of Hail in Hail, Saudi Arabia. Okay, so we will not be closing ito pong ating fun quiz po as we move on to our webinar proper. And for our webinar proper, and we understand everyone very, very excited to get the webinar underway. Hintayin nyo lang po yung mga kasagutan dun po sa ating fun quiz mamaya po after we have had our panel discussion during after the Q&A session po. Let me take this opportunity to introduce our first main presenter. He is a practicing vascular and endovascular surgeon from the Division of Thoracic Cardiovascular Surgery at the UPPGH Department of Surgery. Please welcome Dr. Leoncio Junjun Cao. Dr. Cao.
Hi, good morning, everyone.
Good morning, sir. Please go ahead and share your slides, sir.
Ganyan?
Yan, okay. Thank you so much, sir. Go ahead with your presentation.
So first of all, good morning, everyone, or good afternoon. I'd like to thank the organizers for this opportunity to share our specialty. We are truly honored to be here. So my topic is on the evolution of vascular care at the Philippine General Hospital, focusing on peripheral arterial disease and chronic venous diseases. So to start, a little bit of history. In 1894, then President Francois Carnot, then President of France, died of massive hemorrhage after being stabbed in the abdomen. He was giving a political speech at the time, and in the audience was a medical student named Alexis Carrel. Dr. Carell knew he might have been able to save the president's life if he had been able to do what at that time was considered an impossible task, which is to repair blood vessels. So over the course of how many years, using fine needles and silk threads, Dr. Carell was able to develop techniques to sew blood vessels, which laid the foundation of many vascular techniques used today, including what we now refer to as a vascular anastomosis. Now, fast forward 100 years, in 1990, when a young surgeon from Argentina named Dr. Juan Parodi, using a self-designed graft with expandable ends, a extra large Palma stent, a Teflon sheet with a valve, a wire, and a valvuloplasty balloon borrowed from cardiology, he performed the first endovascular repair of an abdominal aortic aneurysm. Everyone knew that this was something revolutionary, and true enough, that specific case ushered in the endovascular revolution. So since that landmark procedure, we have witnessed a huge paradigm shift in vascular surgery, with a remarkable transition from traditional open surgery to state-of-the-art, minimally invasive catheter-based procedures involving practically all vascular beds and a wide variety of vascular diseases. So for instance, for peripheral arterial disease, we now do angioplasty and stenting instead of surgical bypass. For aneurysms and dissections involving the aorta and peripheral vessels, we can do stent grafting instead of the traditional endoaneurysmography. And this will be discussed more by my colleague, Dr. Cabasa. For venous diseases, we're now seeing a lot of endovenous ablation being done instead of vein stripping. And what are the implications of these to vascular surgery training? Let me start with peripheral arterial disease. We know very well that peripheral arterial disease refers to a circulatory problem which causes reduced blood flow to the arteries. Majority of patients with peripheral arterial disease are asymptomatic. So PAD is defined by an ankle brachial index of less than 0.9. And if they are symptomatic, the symptoms is called claudication, which is pain during walking. These patients may also present with tissue loss, as well as rest pain. The last two being what we refer to as chronic limb-threatening ischemia. Now, until recently, open surgical bypass has been the mainstay of treatment for patients with chronic limb ischemia or critical limb ischemia. There's a plethora of reports which demonstrate the excellent long-term patency and limb salvage rates of infrainguinal bypass. Now, at the turn of the century, the emergence of percutaneous techniques for infrainguinal revascularization has drastically expanded the armamentarium of vascular surgeons. We now are able to provide an effective but less invasive procedure with lower morbidity and mortality, thereby making percutaneous interventions the ideal therapy for the high-risk cohort of patients, typical of those with PAD. So moreover, innovative technologies and novel therapeutic techniques have expanded the indications of endovascular interventions. So as an example, simple lesions such as stenosis, as seen here, or short segment occlusions are now routinely treated in endovascular interventions. So for this particular patient, 49-year-old who presented with a non-healing wound involving the fifth toe, before, without endovascular surgery, we'd have to do a procedure called a femoral enarterectomy, through a small incision in the groin. Now, we just put in a balloon, dilate the vessel, and it looks normal. So in this particular case, 62-year-old male, diabetic with gangrene of the third toe on the right side, he presented with a short segment occlusion involving the distal popliteal artery. So again, historically, we will have to do a procedure called a femoral and posterior tibial bypass, using a vein connecting proximal and here distally. In this particular case, we were able to recanalize it using a balloon, dilate the balloon, and the vessel now looks new with full recanalization. Now, more complex lesions, such as long segment occlusions, were traditionally treated with surgical bypass. Remember that with endovascular treatment, the ability to cross a lesion is a prerequisite for intervention. So, when you come to think of it, the longer the occlusion, the harder would it be. The harder would be to cross that particular lesion. And therefore, some would say that surgical bypass is the treatment of choice. So in this particular case, 59-year-old male with smoker who presents with rest pain involving the left lower extremity, as you can see in this angiogram, he has a high-grade stenosis involving the right common iliac and a long segment occlusion of the left common iliac artery. No? Historically, we would have done a procedure called an aortofemoral bifemoral bypass. No? This entails a huge incision in the abdomen, a laparotomy. You have to clamp the aorta and replace the aorta with a graft. No? Or if they can do stenting or balloon angioplasty, you can actually do a hybrid procedure wherein you balloon angioplasty or stent the right common iliac and then do a fem-fem bypass, getting blood from the right femoral, supplying the left femoral, like so. Now, innovations in technology has really expanded the use of endovascular treatment to treat lower extremity peripheral arterial disease of increasing severity, like the example I just quoted or cited. A number of cutting-edge devices and novel techniques now allow most lesions to be traversed and therefore interventions to be carried out. So this has resulted in a shift away from open surgical revascularization towards percutaneous endovascular therapy as a first option. Here in the Philippines, we have, although in limited quantities, some wires which we can use to traverse a lesion. If we cannot traverse the lesion antegrade, we can do retrograde access. So in the patient I just cited, we ended up stenting both common iliacs, as you can see, with a very good result, a very good outcome. So another example, this is a 55-year-old male diabetic who presented with non-healing wound of the right foot with discoloration of the first and second toes. Over the next 2 or 3 days, this has progressed to really full gangrene with plantar abscess of the said toes. So this prompted the possibility of revascularization. Angiography done revealed an occluded right anterior tibial artery with reconstitution at the dorsalis pedis. The peroneal artery is patent, but with multiple stenotic segments. The posterior tibial artery on this side is severely diseased and almost thread-like. In this particular case, since the dorsalis pedis appears to be a good target, this patient would have undergone a femoral to dorsalis pedis bypass. However, in this particular case, we opted to attempt recanalization and we were successful. We were able to recanalize the right anterior tibial artery, as you can see here. We've improved and eliminated the stenosis of the peroneal artery. And as you can see, there's now direct inline flow towards the right foot. So we amputated the toes and then with very good granulation. There's good bleeding. However, we had to go back after 2 to 3 days to remove the rest of the toes. And as you can see, we were able to discharge the patient with the wound and or the stump granulating very well. So our experience underscores the conceptual goal of endovascular revascularization for chronic limb-threatening ischemia. So rather than striving for durable vessel patency, which we would expect from a surgical bypass, the main aim actually is wound healing and limb salvage. If the vessel occludes or restenosis occurs after the healing period, it may not be so important anymore. So thus it makes more sense to employ an endovascular first approach. And indeed, we in the section of vascular surgery at the Philippine General Hospital advocate this strategy. Of course, we do have limitations. And given the nature of our patients, those limitations are mostly financial in nature. So we do have literature backing or support with regard to this endovascular first strategy. So allow me to cite the Basel II trial, which Basel stands for bypass versus angioplasty for severe ischemia of the leg. This is a prospective multicenter randomized trial in chronic limb-threatening ischemia patients requiring infrapopliteal bypass and just published at Lancet just this year. So the patients were randomized to receive either vein bypass or a best endovascular treatment. And as you can see in the outcome, best endovascular treatment first had a better amputation-free and overall survival compared to a vein bypass first strategy. So in summary, both the basic principles for endovascular or open surgical bypass are more or less the same. We need a straight line pulsatile flow to the foot, which we know is essential for optimal outcome and wound healing. Both endovascular treatment and open surgery both have a role. The factors associated with poor outcome for both are largely unknown, and we know how to avoid them. So the optimal treatment actually hinges on a rational selective approach. most importantly, proper patient selection is vital. No? So if you have a very sick patient, just had a heart attack, you need to recanalize or revascularize the foot, no? Then maybe a endovascular treatment would be a better option, no? Given the patient's comorbidities. No? So, most importantly, let me remind everybody, doing endovascular treatment, that just because we can do it doesn't mean it's the right thing to do. No? Proper selection, again, let me emphasize that proper patient selection is really vital in this case for better outcome or for good outcome. No? So let me now proceed to chronic venous diseases. No? So a while ago, we were talking about arterial diseases. Now let's move forward to talk about venous diseases. No? So chronic venous diseases present in a number of ways. No? Some patients would present with swelling. So a lot of them would present with leg heaviness and aching pain, most especially after prolonged standing, after at the end of the day. Some would present with prominent veins, telangiectasias, varicosities. Some would present with discoloration, skin thickening, a condition we refer to as lipodermatosclerosis, and a few would present with severe stage of venous insufficiency with ulceration. So the treatment of venous insufficiency has been shown to substantially improve health-related quality of life. And we are fortunate to have a wide variety of treatment methods currently available, ranging from venoactive drugs, compression stockings, surgery, and endovenous ablation. Now, while compression therapy using stockings has been the cornerstone of modern treatment of venous insufficiency, endovenous ablation has been shown to be superior versus conservative management in terms of symptomatic relief, better cosmetic results, and much improved quality of life. So when it comes to endosaphenous vein ablation, we have two options. The traditional way is surgery, where we do high ligation and the procedure called vein stripping, and then we can do endovenous vein ablation. In terms of endovenous ablation, we have 4 available techniques or procedures here in our country. They are categorized into the thermal and the non-thermal. For thermal, we have laser, we can use radiofrequency, and non-thermal, we can use glue or cyanoacrylate, and a procedure called MOCA, branded as or marketed as Clarivane. MOCA stands for mechanical chemical ablation, which combines mechanical damage to the endothelium with infusion of a sclerosing agent. Now, the benefits of endovenous ablation is obvious. So you can do it under local anesthesia. More often than not, it's an office procedure. The wound is very small. Patient goes home with a Band-Aid. Less procedure time, minimal pain, and obviously, rapid recovery. So indeed, the literature is replete with data demonstrating the advantage of endovenous ablation over surgery in terms of anatomic success rate, complication rate, prevention of clinical recurrence, post-op pain, shorter time to return to work, as well as cost effectivity in the long run. So it's not surprising that practically all relevant vascular surgery societies advocate endovenous ablation as first-line treatment over surgery in patients with chronic venous insufficiency. So what do I advocate or what I do in practice? I actually prefer cyanoacrylate vein closure. You have to remember that when we use laser or radiofrequency ablation, these are the thermal techniques. These are based on the principle of vessel destruction using thermal energy. Hence, tumescent anesthesia is mandatory to prevent this thermal energy from damaging surrounding tissues, namely the skin and subcutaneous tissue, and for the patient to experience less pain. To me, this is a little bit of a hassle. In contrast, glue ablation is non-thermal. Therefore, patients tend to experience minimal discomfort. They don't even need to wear compression stockings post-operatively because the glue seals the vein right away. There's practically zero chance of nerve damage or any thermal injury, and therefore they can get back to work fairly quickly compared to other modalities. So in comparison, if you look at the literature, this is a study which compares glue ablation to other thermal ablation techniques like RFA and laser. Note that in terms of closure rate, they're a lot better over a 2-year period, and obviously, less complications, less pulmonary embolism, less DVT, bleeding, paresthesia, and so on and so forth. So in summary, glue ablation is really highly effective in the treatment of saphenous vein incompetence, and it offers superior clinical benefits. and better overall outcome. But the biggest downside to this is it's a little bit more expensive. No? So in countries wherein financial constraints is not an option, like in Singapore, no, you could see that this particular procedure is being done fairly commonly, fairly commonly. However, if you have to get out of pocket, that the reality is, in our country, vein stripping or open surgery is actually a cheaper option. Now, what are the implications of this on surgical training? So we always advocate, we always require our vascular surgery trainees to be adept in in a number of in the whole gamut of vascular surgery practice. We would want them to be adept in open vascular operations. We want them to be facile as well in catheter-based interventions, to be knowledgeable in the medical management of vascular diseases, as well as diagnostic procedures interpretation, namely fluoroscopy, as well as duplex ultrasound. The biggest advantage we have at the Philippine General Hospital is that we have the clinical material, we have the expertise, and we have a bit of resources. However, we know that we need more. To be able to maximize open and catheter-based interventions, we need a dedicated cath lab or a hybrid OR. For diagnosis, we need a fully equipped vascular lab. Fortunately, these are already in the pipeline. We envision, hopefully in the near future, for the Philippine General Hospital to have a cardiovascular institute, or to be a center of excellence in terms of aortic management and treatment. So thank you for your attention. I'd be very happy to answer your questions.
Okay. Thank you so much, Dr. Cao. I think there are a lot of questions na po na paparating. No? I'm sure I've at least received 2 questions from direct message. So we'll be posting them later on during the Q&A, Dr. Cao. Thank you so much. Palakpakan naman po. At very, very impressive with regards to just very, very much making it distilled at making it easily understandable for our attendees. So thank you so much, Dr. Junjun Cao. Our next speaker naman po is also from the same division. So he's a practicing thoracic and cardiovascular surgeon from the Division of Thoracic and Cardiovascular Surgery and from the UPPGH Department of Surgery po. So please welcome to your screens Dr. Aldous Cabasa. Dr. Aldous, kumusta?
Yes, good afternoon, Doc Raymond. Good afternoon, everyone.
Good afternoon po. Please go ahead and share your screen, sir.
Okay.
Okay, go ahead.
Okay. All right. So again, good afternoon. I'm Dr. Aldous Cabasa. I'm from the Division of Thoracic and Cardiovascular Surgery of the Department of Surgery in UPPGH. I'm together with Dr. Leon Cao, the first presenter. No? So for today, I'm tasked to give a short lecture on the aortic diseases that we encounter in PGH and the treatment option that we can offer to our patients. No? So just a quick review. No? So the aorta is the biggest blood vessel of the human body. No? So it stems from the heart. It goes up as the ascending aorta and then become a transverse or the aortic arch, then goes down as a descending aorta. And then after it crosses the diaphragm, it becomes the abdominal aorta. No? So the abdominal aorta is further subdivided into either a suprarenal or infrarenal abdominal aorta relative to the renal arteries. No? So from the aorta originates all blood supply of the different organs of the human body. No? So that's how important the aorta is. No? So however, so aorta, like any other organ of the human body, is also subject to wear and tear and eventually develop into diseases. So the most common pathology we encounter in UPPGH are aortic aneurysm and aortic dissection. So to differentiate the two, the aneurysm is dilatation of the aortic wall. So it can be a true aneurysm wherein all three wall layers are involved, or a pseudoaneurysm when partial or part of the wall is aneurysmal. No, on the other hand, dissection is a tear along the layers of the wall. Now, both of which the dreaded complication that we try to avoid is to have a rupture. No, so when it ruptures, parang yun na yun, mawawalan lang ng malay yung patient and that's it. No, so even patient who are admitted in the hospital sometimes won't reach the operating room if they have a rupture while waiting for surgery, let's say in the ward or in their room. No, so as much as possible, we try to avoid having an aortic rupture. No, so in terms of indication for repair, no, so of course, if it's leaking or rupture, we're bound to repair the aorta, no. But for elective repair, so three criteria are usually sought for or looking for a reason for intervention. No? So usually the size. Several studies have indicated the critical size for each segments of the aorta. If there's a rapid expansion, let's say more than 5 millimeter per 6 months, no, or if the patient is symptomatic regardless of the size, no. So usually for thoracic aortic aneurysm or dissection, usually a back pain or chest pain, upper back pain or chest pain. For abdominal aortic aneurysm, usually lower back pain. So as I mentioned earlier, no, in our institution, we can offer several approach to aortic diseases. No, so first approach is the tried and tested open surgery. No, so as thoracic and cardiovascular surgery, this has been the mode of repair ever since. No, so it's done in the operating room under general anesthesia. Usually, we make a midline abdominal incision, and we remove the deflect the bowels laterally for us to be able to get into the retroperitoneal area where the aorta is, where the diseased aorta is, and then we replace it with an artificial blood vessel, which is a medical grade fabric called Dacron graft. No, so as mentioned, the advantage of this is it's a tried and tested procedure. No, however, the disadvantages includes it's a bigger incision, usually more painful post-op. There's more blood loss, usually would require complete cardiac clearance because when we do open aortic repair, we cross clamp the aorta. So we have to make sure that the heart is healthy enough to be able to endure the changes in the hemodynamics after cross clamping. No, most of the time they will need ICU admission, and usually entails longer hospital stay. No, so but as mentioned by Dr. Cao, no, we're starting to introduce endovascular option, no, not only for the peripheral arterial disease but also for the central aorta. No, so for endovascular repair, no, so it can be done under general anesthesia, sometimes regional block. No, usually we go through the bilateral groin, so the incision is much smaller compared to open surgery. No, and then the endograft, no, the stents, we deploy it inside the diseased portion of the aorta. No, so the advantage of this is, of course, is smaller incisions. There's less blood loss. There's faster recovery and early return to activity. The disadvantages of which includes this is relatively young technology. No, so first introduced in the late 90s. No, so yung census nito pick up in the 2000 here in our country. Ito lang mid 2010 onwards lang tayo nag-start dumami yung cases. No, so another proven disadvantage of this is there's a higher reintervention rate. No, so again, with an endovascular repair, we don't anastomose the graft. No, so we rely on the radial force of the endograft na lumapat against the aortic wall, no, in the hope na watertight yung lapat niya, no, para wala tayong endoleak. No, so because of that, no, there's a relatively higher intervention rate compared to an open surgery, and there's a need, well, at least recommended to have a repeat imaging or monitoring. No, kasi we don't have long-term data yet on most cases. So just to give you an example, sorry. So this is a recent data we did just last week. So this is an EVAR for abdominal aortic aneurysm. I'm not sure if it's playing there. No? So usually we do this in the cath lab or operating room with a fluoroscopy. So we shoot an initial aortogram showing the aorta, the renal arteries. No, this is the aorta, and then the iliac artery. So this patient has an aneurysm and the infrarenal aorta. No? So this is the completion aortogram naman after we deploy the endovascular endograph. No? So you can still see the silhouette of the aneurysmal wall, but there's no blood flowing through that aneurysmal sac anymore. So open and endovascular repair have the same goal, which is to divert blood away from the aneurysmal portion or to exclude the aneurysmal segment, and at the same time maintaining blood flow to its major branches. So if you can see here, yung this is part lang yung kino-cover natin, pero yung linear arteries tapos yung flow to the iliac arteries are still patent. So in our center, or at least in our division, since we do both open and endovascular repair. So we tailored based on the clinical presentation of the patient. So we don't just lahat relegate to open or lahat relegate to endovascular. So we usually use published data in determining which treatment is best for the patient. So yun yung common question, ano nga ba yung mas appropriate? So we look at probably yung mga early, midterm, tsaka long-term outcome of EVAR versus open. So if you can see, most survival curve would show na yung EVAR or endovascular repair has a better midterm outcome. Usually yung mga less than 5 years na follow-up, they have better as well. It's an expected outcome similar to all minimally invasive or less invasive procedure. Better yung outcome early on, compared to the open. But after many studies have shown also that after 4, 5, 6 years, nawawala yung advantage of the minimally invasive or for our part, the endovascular repair compared to open. So but in yun nga, since dumadami na rin yung mga naglo-long-term follow-up, so we have this data from Europe, but after 10 years onwards, nag-equalize na ulit yung survival nila. So this is one of the biggest trial or follow-up study. This is one in Europe. In the US, they have the Medicare follow-up, 15 years follow-up na more or less pareho din yung result. So for the first 5 years, mas advantageous yung endovascular, tapos biglang mawawala on the next 5 years, but late after 10 years onwards, equal na yung survival nila. So because of that, so personally, when I talk to patient to help them decide which treatment is better for them, usually pag young patient na we expect na yung life expectancy is, let's say, more than 20 years, 30 years, tapos good surgical candidate, walang masyadong comorbidities, usually I'll go for open repair, At least alam natin yung open repair, tried and tested yan, even 30 years down the road, alam natin kung ano yung itsura ng graph na nilagay natin with an open repair. But if the patient, let's say, is an elderly, very frail, madaming comorbidities, very bad heart, which would probably lead to intraoperative complication, Usually, they are the one na mas appropriate endovascular repair, So usually yun yung ginagamit kong basis on what treatment option to offer to particular patients. So now, as we progress also, so we're seeing more of less yung mga straightforward. I would say around 40% nung mga nakikita namin hindi siya straightforward anatomy. So again, with the endovascular repair, may anatomic criteria siya na nire-require para maging candidate din, So usually maganda dapat yung tawag namin landing zone, yung proximal distal, hindi masyadong tortuous, hindi masyadong angulated, So unfortunately, around 30 to 40% of cases na we've seen, hindi ideal yung yung anatomy, no? In which case, usually, there are more kumbaga, complicated options for them, no? So in other countries, they have the branch graft, no? Wherein ano na yan, ready-made na siya. Dinidesign siya, usually a month yan bago dumating, tapos naka-tailor doon sa patient. So yun yung branch, no? In other countries, they can offer fenestrated grafts, no? So yung usual na ginagamit din natin na graft dito, pero gumagawa sila ng at the back table, gumagawa sila ng hole sa graft then fenestrated, and then through that they insert smaller graft na kakannulate doon sa mga branches na needs to be preserved, no? So this technology, unfortunately, we don't have yet here in the country, no? What we have here and what we've offered to our patients includes this one, yung chivar or snorkel or periscope or sandwich technique, no? So in this technique, we use small endograft, which we sandwich between the aortic wall and the main graft. Tapos may blood flow pa rin through that small endograft. Tapos papunta siya doon sa branch na we're trying to preserve, no? As you can see here, one common problem ng chimney graft or periscope or sandwich technique is hindi siya lumalapat na maayos talaga. So they're very prone to gutter leak, no? So if you can see the picture here at the bottom, no? So may gutter leak kasi hindi siya lumalapat na maayos, no? So this is just one of the case we've done using that technique. Unfortunately, the video is not working. So this is a descending aortic aneurysm. However, to meet the 2 centimeter landing zone at the distal part, we will be occluding the ostia of the celiac trunk, no? So I'm not sure kung makikita dito, but if you can see yung celiac trunk, yan cannulated siya, and then we inserted the smaller graft, no, to the celiac artery, and then tsaka namin dineploy yung longer, bigger main endograft. So this is a follow-up CT scan 2 years after, no? So patent pa rin yung, there's no endoleak, patent pa rin yung graft to the celiac artery, no? And then intact pa rin yung main graft na kinabit natin. No? Then occasionally we also do hybrid, no? Hybrid technique wherein we employed both endovascular tsaka open, no? So for example, in this case, a suprarenal aortic aneurysm wherein the segment above the renal arteries are also involved. Of course, we cannot deploy just one graft above along that aortic segment kasi ma-occlude natin yung SMA, yung celiac artery, and the renal arteries, which is not compatible with life, no? So sometimes we do this yung debranching technique, no? So this is a visceral for the abdominal aorta. So we debranch the renal arteries, the celiac artery, the SMA, and then after debranching, tsaka tayo nagdi-deploy ng mahabang endograft to cover the whole aortic segment na may aneurysm or dissection. Sorry, kulang yung ano na. But this is some intraoperative picture, no, showing yung how the branching looks like. So the one on the bottom, no, so yung isang Dacron graft is connected to the left common iliac artery to supply the left renal artery. So we're also doing the branching technique for the aortic arch. Now, of course, same problem, no? Let's say involve yung aortic arch, we cannot just deploy a long endograft there kasi matatakpan yung ostia ng carotids, which would lead to massive stroke, no? So before we deploy the main endograft, usually we would do a debranching, no? Let's say on this case, we did the LSA to left common carotid bypass, and then carotid to carotid bypass, and then after that, that's the time we deploy the main endograft, no? So to summarize, no, so most common aortic pathology that we see in our institution includes aortic aneurysm and dissection. And in our institution, we offer both open and endovascular repair for patient needing aortic treatment. Thank you.
Okay. Thank you so much, Dr. Aldous. Marami ako natuwa ako dun sa dun sa 3D rendering na gumagalaw kanina.
Yeah, nice, Nice. Very, very impressive for both of our speakers. Ang galing, no? Parang, sabi ko parang ang dali nung ginagawa nila, pero actually.
That's true.
Oh, sige, Raymond, go ahead.
So Dr. Susie, thank you so much. And we're very, very grateful, as mentioned, to our speakers from the Division of Thoracic and Cardiovascular Surgery of the UPPJ's Department of Surgery. Before we jump into our Q&A, we'll just take a very quick break for a special public service announcement today.
Aloy, bilisan mo! Dali!
Ano nangyari? Ba't hindi kita makapitan?
Handa ka na ba, Kaloy?
Oo naman, ate! Nabakunahan na kami. May powers na kami laban sa inyo.
At hindi nyo na kami basta-bastang makakapitan. Yay!
Sisiw!
Kaya mga bata, magpapakuna na kayo.
Stay safe and stay well. Mga bata, magpasama na sa Bakuna Center. Okay, thank you so much, TVUP, the COVID Communication Public Service Announcement. Just one of the many creative outputs that Stop COVID Deaths team to push for COVID-19 vaccination. So please share this in your social media accounts po. Stay safe and stay well. Magpasama na sa Bakuna Center. Okay, we'll start off the ball rolling, Dr. Susie, with the first question.
Okay, well, first, thank you so much to our two surgeons. No, I thought that was really, really fascinating presentations, very graphic, very visual. And you'll see the appreciation of our audience in the chat. And when you were talking, meron mga clapping, all of that. But anyway, I was going to ask you about what brings a patient to seek consultation in terms of the peripheral vascular system. Is it appearance? Is it pain? What is it? What is it? Kasi parang we're looking for parang as you have presented, no, you're being able to evaluate the patient well is very important. But I guess it also has to be done in a timely manner. So, what is the presenting complaint of the patient with peripheral vascular disease? I'm gonna ask June. June, go ahead.
The vast majority would be when they present with a non-healing wound.
Okay.
So I did mention a while ago that there are certain symptoms which tend to be very specific, to peripheral arterial disease. So this will include claudication, non-healing wound, and rest pain. So the sad thing about most Filipinos is that almost always Filipinos don't consult for claudication. If they walk 100 meters, sumakit ang paa, what they do is they'd rather ride or not walk at all, or ride a bike or get a Segway or whatever. But when they have a non-healing wound, that's troublesome. That's when they consult.
I see. So are we saying that once you have some challenges in mobility, that's the time you need to consult? Kasi non-healing wound, parang napaka-advanced na niyan, hindi ba?
Yes. I see a marked difference in Caucasians as well as Filipinos, because we know very well that in the United States or other first world countries, they need to be very independent, and they have they cherish the outdoors and stuff like that. There are a lot of things they do outdoors. They want to be able to walk, they walk in the park and stuff like that. And if they get to be limited in doing that, they consult. Well, in our country, what do you do? Go to a mall? No, that's only a few meters, and there's always a lot of chairs where you can stop every now and then. So sometimes you don't develop the full symptoms.
Right. So parang tinitiis lang, no? Parang
Yes.
tinitiis lang, and then until you get the non-healing wound. Okay, let's talk about the non-healing wound. When you say a person has a non-healing wound, how long is that?
I don't think there's a really a time duration to it, but more often than not, we know very well no, that if you have a wound, no, it should heal no, within a week or so, no, in a normal individual, no.
Kasi I've seen people na they have an unhealing wound, okay? And then they decide to bandage it or lalagyan ng yung dahon ng bayabas na pinakuluan, no, and all of that stuff, or try all kinds of over-the-counter applications. But I guess what you're saying is that if there is a wound, and it's a couple of days and it doesn't get better, there should be consultation, right? And I think for, there are a lot of nurses, general practitioners, family med doctors who are watching this webinar. It's also kind of like a red flag for them. If they see a wound that's not healing, to interrogate a little bit more and ask and see if the patients really need to see a specialist. Okay, so let's see. Dr. Aldous, similar question, right? I know when you have these aneurysms, it's relatively fast, hindi ba? When you have some sort of a dissecting aneurysm in any part of the body, it's rather fast. Are there early signs that people should watch out for?
Yes, no. So as well, it's the classic presentation is usually chest pain, tearing chest pain or back pain. So usually I would ask the patient, when you're having these symptoms, when you have the symptoms, have your blood pressure checked, kasi usually it's always associated with hypertension, no, or high blood pressure po, no. So if they have these symptoms and then they check their blood pressure, it's really elevated, and most likely baka merong ongoing aortic dissection talaga, no. So yun, so usually pain yung most common symptoms or reason for consult in most patients.
Yeah, okay, thanks a lot. Okay, Raymond, over to you.
Thank you, Dr. Susie. The question that I got is mostly from a public health perspective, no? And the question is, paano po dumarating sa inyo yung mga pasyente, yung mga nagpapatingin po sa amin dito sa probinsya, na natutuloy daw po ba silang magpatingin sa mga espesyalista? I guess the question is, when they seek consultation, let's say at the rural health unit or in probably a general medical practitioner in the province, is there like a system in place to refer them if they think it's PAD or something that's vascular in nature, to refer it to a vascular specialist po? Dr. Cao.
I think it's pretty important no, for primary care physicians to be able to recognize no, a vascular disease. In my practice, no, I could say that most of patients who come to me no, come from another doctor. No? So medyo referral based ang specialty natin. So it's very important no, that primary care physicians are knowledgeable and are able to recognize no, a vascular disease and know when to refer.
Okay. Dr. Aldous, how about you? Do you have the same experience as Dr. Cao?
Yes. So I agree with Dr. Cao. No? So yung TCVS in general is a referral subspecialty. So almost always when patient gets to us, more or less complete na yung workup, no? So yung regarding the question, yung mga avenues on how patients from the province can get in touch with us po, no? So actually majority of our patients are from the provinces, no? So lalo na yung mga aorta, we get referral from Ilocos, from Bicol, even from Tugigaraw, no? Madami pong dumarating sa atin na patient, no? So I think we're doing also our effort po para increase yung awareness of the diseases po ng blood vessel, no? So that early recognition and early referral to specialty centers like the PGH po, no? So tapos on top of that, actually nagbibigay kami lecture, no? Dr. Cao and I, before COVID at least, we go around the provinces giving lectures, no? To increase awareness of vascular diseases. Also actually during the pandemic, Dr. Cao come up with parang Facebook Facebook website ng division ng TCVS, no? So actually patients can check that Facebook account, tapos marami nagko-consult. Yeah. So ayan.
Okay.
Yeah, Raymond, I have a question
Yes
here.
po.
It's about varicose veins, and the
Mm.
question is, why are some varicose veins itchy? Makati daw. So what is the explanation for that? So I saw some of your photographs, you were showing discoloration or the lack of circulation, but is that a common sign that a varicose vein could be itchy? Sige, so maybe June muna.
Yeah, actually, no, it's part and parcel of the spectrum of these presentations we see in patients with venous insufficiency. No. Varicose vein is just one of those. There are some patients who have normal lung skin and then they just have large varicosities and that's it. No. They're not even symptomatic. No. And there are some who develop skin changes. No. This come in the form of dermatitis, like photodermatosclerosis. The skin tend to be very dry. Sometimes they're scaly. The skin is thickened. No. So in these patients, sometimes they complain of itchiness. No. So to answer your question, it's part and parcel of the spectrum of presentations in patients with venous insufficiency.
Okay, kasi I think the background of this is when people see that they have something itchy, right? They'll put, again, over-the-counter medications for itchiness, not thinking that there's something that might be going on under. Di ba ganun yung parang, the typical thinking is that, ay makate, baka kinagat, baka ganon, pero actually part siya ng varicose veins. Okay, sige, Raymond, ikaw meron
That's
ka pa
true.
dyan?
Next question will be, is there anything that I can do lifestyle-wise or diet-wise to prevent getting aneurysms or varicose veins? Varicose veins muna, Dr. Cao.
There was a question a while ago, no, na asking if you can take aspirin as a prophylaxis, no, to prevent venous insufficiency, no.
Yes, sir.
I do give aspirin, but it's not meant as a prophylaxis. No? It doesn't prevent anything. No? So in terms of sometimes venous insufficiency, really what I would recommend is a lifestyle modification. No? So regular exercise, you try to avoid prolonged immobilization, try to avoid prolonged standing. No? So I think those are more effective to prevent venous insufficiency rather than medications to take.
Okay, Dr. June, is this hereditary?
So
Varicose
yeah,
veins.
varicosities sometimes, there are some patients wherein 20, 30-year-old pa lang, they present with varicosities, no? And there's also a condition, wherein it's congenital when they present with varicose veins.
I see. Even what do you mean, like when they're born?
Yes, varicose veins being part of a syndrome. No?
I see. Okay, I've got another question here. What is a spider vein? What's a spider?
Spider vein ba? Di ba sa ano yun? Sa atay yun? Sige, go ahead, Dr. Cao.
Spider-Man yata yun eh. Spider
we
vein.
do see that, no? We do see that in the skin. Eh. Yung mga parang, yeah, they look like spiders. Maliliit na prominent blood vessels which are very small, thin. So
Are they
it's just a
bad?
description of how they look.
Yeah, but are they bad? Is it something that needs
Well,
consultation?
it's a sign of venous insufficiency. No?
Okay.
Okay. So venous po yun, no? How about in the aortic side, Dr. Aldous? Same questions. Pwede ba siyang maiwasan with lifestyle or diet? Is it hereditary? Same question, sir.
Yes. So there are several proven factors that might put a patient at risk of developing aneurysm or dissection. So isa na dyan yung smoking, no? So it's a
Smoking.
proven risk, no?
Tama
So
ka
if
talaga
you're a
smoking.
smoker, tigil talaga yan, no? Because it somehow yung affects yung integrity ng aortic wall, which makes it more prone to develop aneurysm or even dissection, no? Of course, so yung mga atherosclerotic diseases, no? So one pathology of developing dissection or aneurysm even is yung mga perforated atherosclerotic ulcers. No? So pag sobrang calcified, let's say, nung wall ng blood vessel, together with other factors like hypertension, mag-crack lang yan, it can lead to dissection or aneurysm. No? So, of course, if you are a diabetic, no, we've all known yung effect ng diabetes, especially kung CKD na, no, very accelerated yung atherosclerosis nila, no. There are also component na hereditary or genetics, no. There are those with connective tissue diseases na very prone to, let's say, Marfan syndrome, or very prone to develop aortic pathology. No, so similar to the peripheral blood vessel diseases, may mga hereditary, may mga acquired. Yung acquired can easily be managed by lifestyle modification.
Okay, I have a question. Of course, it's still on varicose veins, so I guess this is from the ladies. Dr. Cow, is it bad to wear high heels?
I don't see any reason why, how that would contribute to varicose vein formation.
So it's okay.
Yeah, I think so. I think so.
Okay, that's good news for my friend who just asked. Okay, Raymond, go ahead.
Opo, I think that's all the questions I've had, Dr. Susie.
There's one on the Q&A or chat.
There are 4, but Dr. Cao already answered them. So I'm interested actually dito kay Ma'am Monina Santos with regards to CRPS. I'll read the question, maybe Dr. Cao can elaborate some more. Is complex regional pain syndrome or CRPS a differential in cases of patients who have vascular changes and pain on the legs, sir?
To be honest, medyo remote sa akin yung ganong klaseng diagnosis. Patients with varicose vein or venous insufficiency, they do present with pain. Usually, kung sakaling very, very painful, may complication na yun, like they're developing thrombophlebitis, baka nagkaroon sila ng superficial thrombosis and then consequent thrombophlebitis. But the vast majority actually complain of aching pain, yung mabigat ang paa, especially with prolonged standing. And then if you query further, the timeline is very typical of venous insufficiency. They're almost normal during the morning, and then they usually develop the symptoms at the end of the day. Obviously, anything which causes pain, it will always be a differential. I've seen a lot of patients wherein porque may varicosities, ni-refer na kagad sa atin, pero when you query further, ang pain is coming from the knee, radiating down to the lower leg. So on X-ray, meron palang degenerative arthritis involving the knee. So same thing with what the doctor questioned. So it will always be part of the differentials, pero it's not that common. I'd rather deal with rule out the common ones first.
Okay.
So I don't have any more questions here, Raymond. Let me just check.
Me too. The one on aspirin already answered by Dr. Cao. And I think that should be it. Oh, ito, this one, Dr. Cao, maybe you can elaborate some more. From Monina Santos also, when to decide to do surgery in patients with symptomatic insufficiencies?
Well, if they're symptomatic, there was a time wherein our option is only vein stripping versus compression stockings.
Yes.
And my general practice at the time was pag medyo elderly, a lot of comorbidities, pagtiyagaan mo na lang yung stockings. Kasi vein stripping would entail putting the patient on general anesthesia. Although it's a low-risk procedure, it becomes medium risk siguro depending on the comorbidities of the patient and the age. However, now we have endovenous ablation. And this is something which we can do purely under local anesthesia. So first, although we have to evaluate symptoms, how the patient looks, what the duplex ultrasound looks. And if they're candidates for saphenous vein ablation, I would recommend the procedure.
Yeah, thank you, Dr. June. That's remember I was saying at the beginning, back in the day, Raymond, pag may mga varicosity ka, mag-stockings ka, di ba? O magpantalon ka na lang, tago mo na lang, di ba? So I think this is now an option. And I think the last few webinars we've been hearing about new developments and new choices for our patients. So it's good to have both our doctors here. We are very, very grateful for your time, for putting your presentations together. We know it's not easy because you got surgery, everything. Si Dr. Aldos nasa loob pa yata ng OR to.
That's true.
So anyway, let's go to our Raymond, our fun quiz.
Yeah, okay. Can we have the 2 questions po on the screen for our fun quiz? And okay, so for these 2 questions, well, madali po ito, no? First question will be, which parts of the body can aneurysms occur? Well, the correct answer po is letter E. Brain, chest, abdomen, and legs po. Those are really the areas where aneurysms can potentially occur. So, as you can see, 81% of those who participated correctly answered po itong part na ito. They said all of the above. For question number 2, I will ask Dr. Cao to give the correct answer po in terms of what are the benefits of endovascular surgery.
The correct answer is all of the above, no? And I think 89% of patients was able to answer correctly. No? So because
Ayan,
of the smaller incision, less stress on the body, no? Then definitely, no, less blood loss, shorter hospital stay, and faster recovery. So it's all of the above.
Ayan. Okay. Thank you so much, Dr. Cao. So at this point po, no, we'll be asking both of you, Dr. Cao and Dr. Cabasa, to come up with your final messages to our audience. You take the next minute or so to collect your thoughts. If there's anything that you will want to have the audience take away from your presentation or from this webinar, ano po iyon? When while you're doing that, we will move on po dito po sa ating panel discussion poll. So dito po sa ating panel discussion poll that's being shown on the screen is an evaluation poll. Wala po kaming hiwalay na sinesend out po dito. Ito na po iyon. It's a 4-point Likert scale, 5 statements, and I'll read them before our speakers give their final and parting messages. Number 1, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language or technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. So we'll not be closing this. We encourage everyone to participate in this evaluation poll as we move on to the parting words from our speakers po. Dr. Susie.
Okay, so first up, we're going to ask Dr. Aldous Cabasa to give his parting words. Dr. Aldous.
Go ahead, sir.
Yes, okay. So again, yes, sir. Thank you for the organizer, no? So thank you for giving us the opportunity to be part of this very fruitful endeavor, no? So for our viewers or listener po, no? So again, so hopefully our lecture we've imparted yung on how at least to detect yung mga vascular diseases, no? So unfortunately, most of these diseases requires specialties, no? I'm not sure if available in your areas, no? But if kailangan, PGH is always here po, no? So you can reach us. Well, maraming link dyan everywhere, no? On how to reach us. You can send your patients po needing vascular consult or even intervention. So, that's it.
Okay, thank you very much. Let's go to Dr. June. Cao June, go ahead, take it away.
I'd like to thank everybody, the organizers and the attendees, no, for taking time to listen to us. No, it's really been a pleasure. No? My message is, with regards to vascular diseases, you have to remember that delay in treatment have consequences. So, for example, for peripheral arterial disease, if you delay, the condition may worsen, and you can probably you may end up with an amputation. So, for venous diseases, it can worsen, and it's really such a hassle in terms of your lifestyle if you don't seek treatment right away. Again, same thing with aneurysms. There's always that risk of rupture. So basically, the message is, once you've recognized the condition, seek consult early. And the nice thing about, as we've discussed in the past hour, the nice thing about vascular care at the present time is that we have a whole gamut, no, of procedures and treatment options, no, which we can offer to suit, no, what is best for you. So they can be some may entail open surgery, and the vast majority can actually be treated, no, with catheter-based interventions now, no.
Okay, thank you so much to our two very special guests. I really learned a lot from you and really appreciate the very visual presentations and cases that you presented. And so now we are going to our results of the poll. Do you have
Yes.
that already? Okay.
Okay, we very quickly lang po, no, for our poll. Mataas. At least 93% of our participants in our evaluation poll express that they strongly agree. So that's a testament not just to the topic at hand, but also to the level of expertise that has been shared. So again, we'd like to thank the Division of Thoracic and Cardiovascular Surgery of the UP PGH Department of Surgery po, Dr. Leoncio Junjuncao and Dr. Aldous Cabasa for taking the time out from your busy schedule. Maraming salamat po for sharing your insights and your expertise. Thank you so much. And we hope we can have you in our future webinars. Dr. Susie? You're on mute, ma'am.
Okay, thank you very much. So we're going to our closing remarks and we'd like to welcome ang isang haligi ng Stop COVID Deaths, Dr. Stella Legazpi Jose. Stel, take it away.
Ma'am Stella will not be able to join pala as Dr.
Wala
Susie
si Stella.
because of her convention. But then nonetheless, I'll be the one to just give a quick
Sure. Go ahead, Raymond.
So very thankful again to our speakers. So first off, focusing on the peripheral and the venous side of it. So advances in the vascular therapy have broadened the options for treating peripheral vascular diseases percutaneously, and the timing and need for revascularization very broadly related to claudication, critical limb ischemia, and acute limb ischemia. So ito pong endovascular procedures considered when these are considered when yung pong mga regular po na mga nire-recommend such as exercise or medical therapy, when these fail to improve quality of life, endovascular procedures are then recommended. In general, ito pong endovascular treatments have greater long-term durability for such diseases than femoral popliteal disease, such as aortoiliac disease. Meron din pong benefits ito pong endovascular surgery such as shorter hospital stay, maliit lang po yung incision, there's faster recovery for the patient, and really making sure that they are back to their daily activities of daily living po with regards to that one. Also, you should have noticed very important also on the aortic side, kailangan din po nating mga babantayan. And as much as I was impressed with the hologram or 3D rendering po nung sa heart and the aorta, very important are the preventive measures. So number 1 po, wag pong manigarilyo, stop smoking, something that's really been hammered into us, very important as we try to take care of our vascular system po, no? And really just trying to make sure that we eat right, so exercise din po, and trying to, if you feel that there's something, let's say there's pain or a non-healing wound, usually po kasi we try to brush it off, madali po yan gagaling, or baka diabetes or whatever. But if there's a need for us to be able to consult with vascular specialists, then you should really seek them out. Over to you, Dr. Susie.
Okay, so we'll see you again next week. Raymond, ano yung topic next week?
Topic next week is about deafness awareness. Yung po ang
deafness. Okay,
yes.
yeah. Sorry, I forgot about that. Okay. You know, there's a lot of interest in deafness and a lot of young parents who discover that they have children who are deaf. But deafness can occur at any age. And I think this is a really very exciting topic. In fact, some people, in the United States, we're saying that some people are diagnosed as having dementia or Alzheimer's, but actually they're just deaf. No, so I think this is a very good topic, and we will talk about prevention And again, we will bring you the best speakers next week. So please join us when we talk about deafness. Over to you, Raymond.
Okay, thank you so much, Dr. Susie. Maraming salamat po. Before we conclude with our program, we'd like to invite everyone to watch in the playback po all Stop COVID Deaths webinars, which are archived for viewing at the TVUP YouTube channel. So you just open up your app and you search for TVUP, or you go to your browser po and type in www.youtube.com/TVUPPH for you to be able to see all 170 webinars. After today, it will be 171. We also have part din po nun, sa isang tab, yung shorts po, yung SCD shorts po natin. These are selected presentations. Very, very easily consumable. 1 to 2 minutes po in duration. And you can also watch them at your convenience at the TVUP YouTube channel. So same link din po iyon. Okay? So this formally closes our webinar for the week. And we look forward again to your company on next Friday from 12 noon to 2 p.m. It's a date.
Together, we can stop preventable deaths.
So keep safe, keep healthy, and see you online.